Professor Dalia Helmy هترد لنا على ال questions about the immunological aspects of patients having hematological diseases أو يعني cytopenias. اتفضلي يا فندم.
بسم الله الرحمن الرحيم. شكرا لحضرتك دكتور عزة على يعني ترتيب الجلسة. ان شاء الله يا ربي احسبها تكون مفيدة لكل الدكاترة بإذن الله. وشكرا لحضرتك دكتورة جليلة، وجود حضرتك إضافة في كل حاجة. وشكرا يا أحمد ل your elegant presentation and giving an introduction about the inflammatory bowel disease. وانت طبعا a very good consultant لينا في الحالات presenting with gastrointestinal involvement. I have none to disclose, and the learning objectives of these lectures will include the aim of the attendee to understand the broad spectrum of inborn error of immunity with associated hematological and gastrointestinal autoimmunity, become aware of the possible IEI-related phenotypes of the specified autoimmunity, recognize when to do genetic testing for presenting autoimmune disorders, understand the implication for correct genetic diagnosis of IEI-related autoimmunity. So starting with the inborn error of immunity, this is a new name given to the old name primary immune deficiency diseases, and mainly because all these disorders have inborn error of genetics that lead to this presentation. The classic red flags for inborn error of immunity include susceptibility to multiple or severe infectious disease, high recurrence of infections, severe infection with the need for hospitalization, use of intravenous antibiotics and delayed resolutions, infection by unusual pathogens or restricted pathogen susceptibility, like increased susceptibility to Epstein-Barr virus, increased susceptibility to mycobacterial disease, fungal infections. And this is the Jeffrey Model Foundation Classic 10 warning signs, including the different phenotypes of infections, in addition to family history of established PID diagnosis. However, the inborn error of immunity had another face for the coin, which is immune dysregulations that could be expressed as autoimmunity, atopy, lymphoproliferation, and it is not surprising that if I said that these manifestations represent the first sign of inborn error of immunity in nearly 10% of these patients. What makes things complicated that some of the newly identified inborn error of immunity have a predominant immune dysregulation phenotype with a very minor susceptibility to infection that unfortunately could be missed by some physicians. So in this figure, we can see that there is extending paradigm of inborn error of immunity and two phases, which is the classic immune deficiency disorder with increased susceptibility to infections, and the immune dysregulation phase ranging from autoimmune cytopenia, lymphoproliferation, cancer predisposition, allergic disorder, endocrinopathy, gastrointestinal involvement, and systemic autoimmunity or systemic vasculitis. And I like to do this figure to see how far the causes of inborn immunity only for the hematological and gastrointestinal immune dysregulation have a very broad spectrum of disorders. In this intersection between the two circles, they have common feature and common involvement of hematological as well as gastrointestinal autoimmune disorder, starting from severe combined immune deficiency less profound than severe combined immune deficiency, even with those with syndromic features, predominantly antibody deficiency, phagocytic disorder, CGD, chronic granulomatous disease, defect in the innate immunity, and disease of immune dysregulations, what's called trigopathies, which means defect of the Treg cells, and autoinflammatory disease. These are all sharing the hematological and gastrointestinal involvement. In this far side of the circle, this is specific peculiar hematological autoimmunity, and in the other side, gastrointestinal, which is very important, as Dr. Ahmed said, that very early onset inflammatory bowel disease should be screened for underlying inborn area of immunity, and this is very important and should not be overlooked. So coming to the hematological immune dysregulation, the most common is autoimmune cytopenias like immune thrombocytopenic purpura, autoimmune hemolytic anemia, autoimmune neutropenia. These are the most common presentation of hematological immune dysregulation. And it is very interesting to know that patient with inborn area of immunity has 120-fold high risk of developing autoimmune cytopenias, especially for autoimmune hemolytic anemia, compared with non-IEI patients. And an interesting study found that nearly 40% of 80 children presented with event syndrome had pathogenic mutations in the IEI causative genes, ranging from autoinflammatory disease, ALPS, trigopathies, and ALPS-like disorders. The other side is the benign polyclonal proliferation, which is expressed by lymphadenopathy, significant more than 1 centimeter, and splenomegaly in absence of hemolysis, involving many different IEI like CVID, common variable immune deficiency, Viscott-Aldrich, activated phosphoinositide 3 kinase delta syndrome, which is there is a debate between its differentiating as a combined immune deficiency or predominantly antibody deficiency. The autoimmune lymphoproliferative syndrome, monogenic disorder with Epstein-Barr virus susceptibility, trigopathies, and others. We are talking about the hematological and gastrointestinal autoimmunity and immune dysregulation. However, the hematological involvement in IEI is far beyond this spectrum, like the bone marrow failures and the increased susceptibility to cancers. Concerning the phenotypes of IEI-related gastrointestinal immune dysregulation, we include early onset enteropathy, which is manifested by severe watery diarrhea, bloody stools, marked loss of weight, inflammatory bowel disease, granulomatous colitis, which is a specific involvement in patients with chronic granulomatous disease, IBD-like, and celiac disease, which is a common association with selective immunoglobulin A deficiency and less with CVID. So I aim to put clinical clues to identify patients with the most probable IEI underlying the presenting autoimmunity, like early age, unusual early age at disease onset. Like Dr. Ahmed said, that patient with pediatric onset inflammatory bowel disease commonly like around 15, 17, and early onset if they are like 10 to 15. But if it is come to, or less than, but if it is less than 5 years of age, or neonatal onset inflammatory bowel disease, or in the first year of life, this could never be overlooked. Also, early onset of event syndrome, chronic course of the disease, refractory to conventional treatment, relapsing disease, not responding, multiple autoimmune cytopenia, syndromic facies, the patient has dysmorphic facies, skeletal dysplasia, associated lymphoproliferation, family history of similar disorders, consanguinity, unexplained failure to thrive or stunted growth, because certain IEI disorder has a feature of stunted growth or unexplained failure to thrive as a part of the disorder. And lastly, because it should not be missed, if the patient has history of severe or unusual infections, this patient could not be missed and should be classically screened for inborn error of immunity. But the most complicated situation when this patient present with minor infections and predominant autoimmune feature, but have these features, this patient should be screened for the basic immunological test, but please in collaboration with pediatric immunologists, because there must be specific and accurate interpretation of these tests, and not all tests are done at the same time. No, it is selected according to the patient's situation, and there should be genetic testing, very important. If we can see that 40% of patients presented with event syndrome were found to have genetic causes for inborn error of immunity. So genetic testing is very important. It's not about I have the patient to must be presented with recurrent infection to be genetically screened. No, any abnormal or any suggestive features that this patient is not a simple autoimmune disorder, polygenic or multifactorial, this patient should be screened genetically. And what is the important to have genetic diagnosis of this patient? The treatment is challenging because if I identify this patient as having inborn error of immunity with susceptibility to infection, there should be careful balancing of immunosuppression versus the possible risk of infection in this patient. Moreover, certain biologicals should be cautiously used or even contraindicated in patients with certain susceptibility to organisms because this biological as adverse effect increase the occurrence and the possibility of having this infection. And very important that the ability to define the pathophysiology of this disorder lead to targeted therapeutic intervention, what's called precision medicine, means I target the specific defect in this patient in addition to the very important role of hematopoietic stem cell transplantation in this patient, especially in patients with very early onset inflammatory bowel disease, mostly refractory to biological treatment and the conventional treatment of IBD, and they need stem cell transplantation. I will not go through this table, but this is a very nice table showing how far the identified defect in the inborn error of immunity found a targeted therapy that is directed to the underlying disorder of this patient, making the treatment more effective and with less adverse effect. Thank you for your attention at the end, and I would like to thank the PER team. And I want to invite you all to, inshallah, our coming Congress, 25th and 26th of October at Cairo Sheraton Hotel, and it is accredited by the American Association of Continuing Medical Education. Thank you.